Good afternoon. We have a rather pleasant task. This is plenary number 10 of this Congress, and the topic is, can surgery really be compassionate? Now, I think that's rather a rhetorical question. I always thought that surgery was compassionate, but never mind. To talk to us about this topic, we have a very eminent personality with us today, and that is Professor Abhay Rane. I really think that he does not need to be introduced because I think his citation was read only a couple of days ago, so it would be rather overstating the fact if I try to do it again. So without much ado, may I please ask Professor Abhay Rane to address the gathering. Over to you.
Thank you, Ranil and Nisanka. It's a pleasure to be here at the college, and I'd like to thank the college, RCS Ed, and the SARC Surgical Society for the opportunity. As Ranil mentioned, is there a pun in the title? And that's something that we'll try and resolve over the next few minutes. What does it mean when you're compassionate? And you can look at different dictionaries, but the simplest thing is that if you feel or show sympathy or concerns for others, then you're compassionate. Are we as surgeons compassionate? I think we are. But this talk wants to look at whether we are compassionate as surgeons to the patient, whether we are compassionate for the planet, and finally, are we compassionate to ourselves? So it's kind of a different concept on being compassionate. And bear with me, we'll just run through these one by one. So let's talk about being compassionate for the patient. Now, there was an anatomist called William Hunter. Some of you may have heard of him, very famous anatomist. And basically, he wrote in the 17th century that anatomy informs the head, gives dexterity to the hand, familiarizes the heart with the necessary inhumanity to allow us to cut. And then, that's a very interesting phrase from an anatomist, and that leads you to wonder whether he wanted to steal the surgeons of those days to actually not be compassionate. Hold that thought. Fast forward. This is the 19th century. I've picked this from the Journal of Compassionate Surgery, Compassionate Healthcare. And it, the article hasn't projected very well, but what it does say is that sympathy and compassion for the patient were a vital part of surgery in the 18th and 19th century. So I think we had moved on from the anatomist's perception to what surgeons thought. Sadly, the Journal of Compassionate Healthcare is now out of print. That, again, tells us something. Perhaps it wasn't considered to be as important a topic as perhaps we do consider it to be nowadays. And then just let's go through what it means for being compassionate to the patient. I mean, these are patients who are terrified. They come into your surgery, they're not quite sure what's going on, and they naturally want to know, will there be side effects from my surgery? Will I recover? Are there going to be long-term consequences? Will I cope if I've had this surgery? How am I going to kind of deal with day-to-day life? How are my relatives going to cope? And finally, in some healthcare systems, there's a cost implication as well. So, a poor patient has all of these things to think about even before he's had his surgery. So it is something that we need to factor into our counseling and whatever we talk to our patients about. This is not a plug for this book, which just came out this month, but I thought in chapter 1, we've put this in, that the importance of the patient-surgeon relationship is paramount. And in fact, box 1 in chapter 1 says that we have to communicate clearly, openly, and compassionately with all patients. So the word compassion is being kind of used regularly and in different contexts. And Jackie said that in her talk as well. So, we're coming back to the same equation. Let's just hold that thought for a minute and talk about the planet now. As surgeons, are we compassionate to the planet? Well, arguably not. to a degree. You look at different statistics and different figures come up, but surgery accounts for about 6% of our carbon footprint in the UK. Anesthetic gases are a big proportion of that. 5% of the NHS carbon footprint comes from anesthetic gases. About half of the carbon emissions related to a surgical procedure come from anesthetic gases. So any anesthetists out there, we need to work together to help and reduce this wherever we can. Let's look at carbon footprints of fairly common operations. If you were to have a cataract operation in the UK, it generates 182 kilograms of CO2. The same operation done in India generates 6 kilograms. And that's to do with infrastructure, theaters, etc. If you were to move on to robotic surgery, a robotic hysterectomy in the US generates 814 kilograms. And that's equivalent to driving more than 2,000 miles in a petrol car. So we do generate a lot of CO2 as surgeons. I don't think that's being compassionate for the planet. So what are our options? And many of you must have seen this film, Back to the Future, where things weren't what they quite seemed, and then they changed. And this is what perhaps we could look at doing, and this was alluded to in one of the earlier talks. You can reduce your carbon footprint by moving from single-use to reusable products. Now, COVID kind of put a damper on that, and so this whole project of trying to rationalize our single-use equipment status kind of fell by the wayside. But we're coming out of that now. So I think we need to look at ways and means in which we can reduce our carbon footprint. So you can move from single-use to reusable surgical devices. You can use reusable textiles rather than paper ones. You can reuse anesthetic drug trays, laryngeal mask airways, laryngoscope handles and blades. And so all of these things, add up. And you've got to start somewhere. So I would put it to you that if all of us did a little bit, it would make a big difference. And this was highlighted by Mahmood Butta, who is a really talented ENT surgeon based in Brighton. And he mentioned all of these at the President's Conference that we had in Glasgow, and Rowan was there, so he will remember this slide being put up. And he had this beautiful set of photographs of, thousands and thousands of laryngeal blade, handles and blades just being chucked away after one use. So I think it really did make me stand up and kind of wonder as to why we did that. There have been a number of trusts, hospitals in the UK, which have tried to do things differently. Now, this is from Leeds. And they do appendicectomies differently. So they, instead of insufflating with gas, they have a special retractor. They've started to use reusable gowns. They don't catheterize patients routinely. And they've started to reuse instruments wherever possible. And they've calculated that saved about 100 tons of CO2 per year just by doing something as simple as that. Now, there is something in this, and all the surgical colleges came together and pulled together this intercollegiate green theatre checklist, which again is fresh off the press. Again, was kind of first. I became first aware of it 2 weeks ago. So this is something that you can access freely. It's on every college website. You just go into it and pop in, intercollegiate green theatre checklist, and it goes through what you can do. I'm really sorry it hasn't projected very well, but if you can even get the QR code, you can access it. But it gives you an overview of what you can do, and then at the beginning of theatres, you can start ticking off boxes. And even if you can't tick off all of them, you can start ticking off a few of them. So it is a concerted effort made by the surgical royal colleges to help the environment. And I think that is us being compassionate to the planet. And as surgeons, I think we owe it to our planet to be compassionate. having said that, I think I've got a few more minutes, so let's talk about ourselves. Let's talk about surgeons. Are surgeons compassionate to themselves? Do we look after ourselves? And self-compassion is recognizing that you deserve to put yourself first, because if you don't look after yourself, you won't be able to look after others. And we talked briefly about burnout and talked briefly about patients, about surgeons giving up their work, looking at a better work-life balance. This is a really good review article. It's from Nigeria, but you know, what they've looked at is a global status of burnout and the prevalence, and it's about 50%. This is a meta-analysis of all the articles out there, and it's really well written, so I'd strongly recommend you look it up. And naturally, you know, most of the respondents were from the US, so you can see the US bar chart is quite high. If you look at Asia, there's Pakistan there and Singapore, but then you think, well, actually, does this apply to Sri Lanka? Does this apply to the Southeast Asian subcontinent? Well, yes, it does, because here's another paper. This is from South Asia, and it's exactly the same sort of data, and they've come out with strikingly similar, you know, kind of data to say that there is this burnout. They call it the second victim syndrome. It's a play on names, but again, they're asking the same questions and coming up with the same recommendations. We need to do something for surgeons to make sure we are better prepared to deal with all the emotional trauma that we shoulder day in, day out. I'm going to spend a minute on this one. This is a good friend of mine, Scott Egener. He's a Chicago-based urologist. And he wrote this after a patient died while he was operating on him. He had a large renal tumor, and he wrote this article, very, very poignant article, and it was published in the New York Times. And he says, he bled to death before my eyes, belly open, my hands inside him. And it changed him as an individual. And you know, he's now written a lot of stuff about, you know, how difficult it is to deal with losing a patient, you know, and how the trauma kind of can consume you in your career. So I think that there is a lesson here for all of us. You need to rethink about what is also important. You're also important, very important. And various coping mechanisms are out there, and this is just one kind of algorithm that this chap Feingold has come out with. You need to look at your relationships, perhaps determine what is more important, you know, rekindle relationships that perhaps haven't been at the forefront because you were working so hard. You look at how you can engage with colleagues, with friends in different ways, how you can feed off each other, look at support, maybe do something to regain your vitality, whether that's sports, whether that's doing something different, extracurricular. You have to look at how you feel accomplished. You know, work is great, but it's not everything. You can look at how you can, your feeling of self-accomplishment can be perhaps boosted by taking on, you know, other challenges. And then what does it all mean for you, you know, at the end of the day? Just rationalizing that and thinking positive. So these aren't just words. These are algorithms for each of us to unpick and work towards the best way we can. I think this was a great choice, and I'd like to congratulate the academic committee for choosing this sort of left of center, slightly woolly topic about compassionate surgery. And I hope I've been able to give you my side of what I think is important when we talk about compassion, both for the surgeon, for the patient, and for the planet. Thank you very much. From my college, Conjurat Amice, that is our motto. It's on our little logo. It's over here as well. And basically it means in friendship. Thank you for your friendship.
Thank you very much, Professor Abhay, for that very enlightening speech. Thank you.